Hello, everyone, and welcome to the 6th annual MCBK meeting. This is our second global and fourth year virtual meeting. I'm Chuck Friedman. I'm the chair of the Learning Health Sciences Department at the University of Michigan. I'd like my colleague, Philip Scott, now to introduce himself to you briefly.
Thank you, Chuck. Yes, I'm Philip Scott. I'm Professor of Digital Health and Care at the University of Wales, Trinity St David in the UK, and working with Chuck as co-chair of the MCBK Global Conference for 2023.
Thank you, Philip. We now very much want to acknowledge the very, very hard work of the program committee, our presenters, and we have many presenters at this meeting, and our meeting staff for their enormous help in making this meeting possible and arranging a terrific program for you all today and tomorrow. This is a two-day event with two sessions at different times to accommodate our global participants. This morning's session will be 4 hours on Eastern Time from 9 a.m. to 1 p.m., which is 10 a.m. to 2 p.m. For those joining us from much of South America, 2 to 6 for those in the UK, and 3 to 7 in Central Europe. We're using an IBM platform to stream the keynote speeches and lightning talks. You'll be able to access the video recordings on the IBM website after the meeting by entering in your name and email, same as you did for logging into the meeting today. There will be Q&A for the keynotes through the IBM platform and Zoom meetings for the lightning talks, for which we will share the links with you. So now I'd like to run through a set of slides that will introduce the program in more detail. Slides are visible.
You have the slide? Yep.
You see them on the monitor?
Yes, okay, good. Wanted to make sure everybody could see the slides. So greetings again around the world. Here is a summary of the times around the world corresponding to where we are now. We know that over 500 people have registered for this meeting and will be joining at various times, and they represent more than 40 nations. It was 47 at last count and may have climbed up over 50 by now. I mentioned that this was the 6th annual meeting and the second manifestly global meeting. It's a two-day meeting. We're going to try to accommodate almost everyone everywhere in the world with the way the sessions are spread out. This session, and in fact all of the sessions, will be 4 hours in duration. Recordings will be available, and as I said previously, you will be on the IBM platform for this part of the meeting and Zoom platforms for breakout discussions. So let's get to the substance of why we're all here. And I believe, and Philip believes, and I think that many of you believe, that the reason we're all here is to promote better health for everyone in the world. Quoting our colleague Jeffrey Braithwaite, who said very pointedly that the three numbers you have to know about the current state of healthcare are 60, 30, and 10. 60% of care on average is in line with evidence or consensus-based guidelines. 30% is of some form of waste or low value, and 10% is harm. This challenge has persisted for 3 decades, and MCBK is basically formed and targeted to address this challenge, and it's going to address this challenge. It has started, as you'll hear in this meeting, to address this challenge by making trusted biomedical knowledge widely available in computable form, and that will be the key, we all believe, to better health in the 21st century. It's important to emphasize that this is a meeting about knowledge. And puts knowledge in the foreground. Data are very important, but in this meeting, in the context of this meeting, data are really in the background. To think about what knowledge is, one way to grasp this concept is to think about knowledge as a result. And the result in particular of an analytical and/or deliberative process, it could be both, that holds significance for an identified community. computable biomedical knowledge puts this knowledge, these results, into computable form. And we focus this meeting on knowledge because data by itself, no matter how important data is, does not directly save lives, whereas knowledge can. Many of us who follow and participate in MCBK also hold dear the concept of learning health systems and the idea that improvement occurs using methods, iterative methods, also known as a virtuous cycle or an improvement cycle. And if you look at the cycle as depicted in this slide, you'll see that knowledge resulting from the process of taking data to knowledge is the keystone that holds this cycle together and enables a smooth transition from the data to knowledge phase to the implementation phase, taking knowledge to performance. And therein lies the problem. Right at the very top, without a keystone, without something to facilitate the transition from data to knowledge, that is the discovery part of the cycle, and knowledge to practice, that is the implementation part of the cycle, there's a gap. And we know there's a gap there because of the very, very significant body of literature documenting that there is an enormous latency, an unacceptable latency of many, many years, often placed at about 17 years between discovery of new biomedical knowledge that can improve health and healthcare and the widespread implementation of that knowledge in practice. A fundamental MCBK proposition, and the reason I believe many of you are here, and I know it's the reason why Philip and I and our colleagues and presenters at the meeting are here, is the belief that closing this improvement gap requires the knowledge to be in computable form so that implementation of that knowledge can occur efficiently, sustainably, and at scale. Moreover, the world needs an infrastructure that makes computable knowledge fair, findable, accessible, interoperable, and reusable, and trusted, so people will put it to use and everyone in the world can benefit from its use. This is what MCBK stands for, and the world, therefore, needs MCBK. A little bit of history. As implied by everything I said before, MCBK is a multi-stakeholder movement to mobilize fair and trusted computable knowledge. There was an organizing meeting. It was an invitational meeting in Ann Arbor, Michigan in 2017 that established the viability and importance of an MCBK movement. This was succeeded by two open, fully public in-person meetings that were held at the National Institutes of Health in 2018 and 2019. And then a wonderful thing happened in 2019. There was an MCBK UK meeting in London that was extremely successful. Philip Scott emerged, and along with Jeremy Wyatt, as the co-chairs of what has come to be called MCBK UK. And this movement in the United Kingdom that began at that 2019 meeting really planted the seeds for MCBK to be global. We see here a picture of the late John Fox, a major supporter of MCBK who sadly passed away a couple of years ago. We had open virtual meetings due to the pandemic in 2020 and 2021 and moved to virtual global meetings in 2022 and again, of course, this year. So this brings us to the structure of the meeting in a little more detail than I talked about before. We are here, day one, session one, Tuesday, October 3rd in most of the world. And we believe that this session will be, unless people in Asia and Australia like to stay up in the middle of the night, will be primarily for people in the US and Canada, the UK, South America, which is not listed here, but is 1 hour later than us, most of South America, and folks on continental Europe who are on Central European time. And of course, that's where we are in this first session of this first day. This will be followed by a day one, session 2, which is very, very similar in content if you've looked at the program, which will take place at 7 p.m. U.S. Eastern Time, but importantly at 7 a.m. to 11 a.m. on October 4th in China, 10 a.m. to 2 p.m. In Eastern Australia, both on October 4th on their clocks. Very similar content, but if you are interested in some of the variation that's going to take place from session 1 to session 2, or if you are a presenter of a lightning talk, you are very welcome to attend both sessions, and we very much hope you will. Tomorrow, we will have day 2, session 1, which convenes at 9 a.m. U.S., Canada, Eastern Time, and then the final session of the meeting will be day 2, session 2, which convenes at 7 p.m. U.S., Canada, Eastern Time, with the same time conversions to the other time zones. For those of you who prefer to see things in tabular form, here is basically the same information in tabular form. So the full meeting, looking across all 4 sessions, day 1, sessions 1 and 2, day 2, sessions 1 and 2, will consist of 6 plenary presentations and what might be called panels with multiple presenters. We're going to have 2 of these on day 1 and 4 of these on day 2. There will be 4 parallel sessions on day 1, immediately following our opening plenary, following in a moment. And one of those parallel sessions is an orientation for newcomers. We know that there are well over 250 people registered for this meeting who said this was their first MCBK meeting. So we hope those of you who fall into that category will partake of this orientation. And then at the same time, there will be 3 presentations of MCBK in action, different stories of MCBK in action. Then we will have lightning talks, 28 of them, in 2 rounds later today. These lightning talks will be shown in thematic breakout rooms with authors present for discussion. In other words, and we're going to go through 2 rounds of lightning talks, which means you can go to one room where you can participate in round 1 to hear a selected subset of the talks of interest to you. And then in the second round, you can go to a different room and participate in the discussion and watch other lightning talks of interest to you. Tomorrow, we'll have some hot topic thematic huddles in breakout groups, and then also on day 2, we will have regional and national huddles, which will be opportunities for people from the same part of the world to talk about work of their chapters that have formed, work of their chapters that are forming, and in other cases, the possibility to form chapters in their regions or nations that have not taken shape yet. So this session in detail, welcome overview, that's happening now. We will then have a plenary presentation by Alan Lebrique with Paula Otero of the Hospital Italiano in Buenos Aires, Argentina, moderating the Q&A and offering some comments of her own. Then the 4 parallel sessions that I just mentioned, followed by Lightning Talk Session 1, where you will get an opportunity to go to one of 6 rooms and hear the lightning talks and speak with the lightning talk authors in that room. Then after a break, you will have an opportunity to go to a second room and partake of a different set of lightning talks of interest to you. And we'll close the morning with a plenary conversation of Mark Musin and Karen Verspor, US and Australia, talking about the very pertinent topic of large language models and how they relate to the concept of more discrete approaches to AI and computable knowledge that really have been the focus of MCBK up to this point. Technical information, just reminding you, during the plenary talks, submit your questions as soon as you think of them. There's a Q&A option on the platform for you to do that. As mentioned, we're going to be using two different platforms, IBM for plenaries and Zoom for parallels. And the use of Zoom, as we have learned from doing this in past years, will greatly facilitate interactive discussions in these smaller groups. Below your IBM video player window is a link to a document that has the information to join all Zoom meetings. So to get into those Zoom meetings, all you need to do is access that document and click on the Zoom link corresponding to the room to which you want to go. And finally, below the IBM video player, on the video tab are links to the recordings once they become available. So that completes this brief introduction. And now I would like to introduce Alan Lebrique's very, very important and pertinent plenary talk on smart guidelines, rethinking digital assets to deliver global health 2.0. Dr. Lebrique is director of the Department of Digital Health and Innovation at the World Health Organization. He's the founding director of the Johns Hopkins University Global mHealth Initiative and editor-in-chief for the Oxford Open Digital Health Journal. He's an infectious disease and population endocrinologist who served until September 2022 as professor and the inaugural associate chair for research in the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. He served as a lead author on the 2012 Bellagio Declaration on mHealth Evidence, and his frameworks for digital health remain among the most cited of his many works. Alan has served as a technical advisor to several international and global health agencies and ministries of health around the world, and was chair of the committee that generated the WHO Digital Health Guidelines. So it's my pleasure now to introduce Dr. Lebrique and his presentation on smart guidelines and his very, very critical work in the WHO.
Greetings from Geneva, Switzerland. I'm Alan Lebrique, Director of the Department of Digital Health and Innovation in the Science Division of the World Health Organization. Thank you so much for the kind invitation to speak to you today. I only regret that I was not able to be with you live, but do hope that this won't stop you from reaching out with any questions or opportunities to collaborate. WHO has had a long history of supporting the digitization of health systems since the first e-health resolution was passed by member states at the World Health Assembly in 2005. However, it has only really been in recent years in which WHO has shifted the thinking of supporting digital health projects to the wholesale digital transformation of health systems, with the publication of a number of guidance documents, such as the WHO Guidelines on Digital Health Interventions and the Global Strategy on Digital Health, and the first SMART Guideline, which was published in 2021. The Global Strategy on Digital Health, which was adopted by all 194 member states during the World Health Assembly in 2020, outlines the key strategic objectives to help improve health for everyone, everywhere, by accelerating the development and adoption of appropriate digital health tools to achieve the health-related SDGs. The four objectives, as you see here on the screen, are: 1, promote global collaboration and advance the transfer of knowledge on digital health; 2, advance the implementation of national digital health strategies, which we appreciate as being the foundation stone for effective rollout of digital health activities at a national scale, to strengthen governance of digital health at a global, regional, and national levels. And last but not least, continue to advocate for people-centered health systems that are enabled by digital health. With this strategy, we envision a future in which WHO can not only support countries to adopt digital health solutions for health system strengthening using best practices, but also have WHO provide more precise and contextualize guidelines that are appropriate for the digital age. Thus, ministries of health can reduce the time and costs associated with adopting digital solutions for health, while also reinforcing guidelines-adherent care and have greater access to data to facilitate public health decision-making. Technology partners can more easily adopt clinical and public health guidelines with fidelity using interoperability standards, thus enabling greater competitiveness of local talent. Health workers have a reduced reporting burden and greater support for their day-to-day tasks, including access to evidence-based clinical decision support, and ultimately, a world in which individuals, patients, clients, or health service users obtain higher quality of health services and gain greater control over their own health data and their own health journeys. Thus, as part of the normative support that WHO has a mandate to deliver, we are investing more time to provide our evidence-based content in digital-ready packages, bringing the mandate of public health data and clinical normative content into the digital age to support digital transformation rather than bringing more siloed apps for individual users. Our goal is to ensure that countries have the evidence-based guidance and packages of validated digitized contents and tools to effectively plan and implement impactful digital health systems for all. As part of phase 5 of the process outlined in the Digital Implementation Investment Guide, determining the health content requirements, the SMART guidelines provide WHO normative evidence-based recommendations in a format that's more easily adapted and used by technology partners who are tasked with developing the digital health solution for, say, a Ministry of Health. The SMART guidelines approach has a 5-layer knowledge framework. L1 is the narrative guidelines in which WHO already publishes a narrative PDF format that's geared towards policymakers to support the adoption and change of health policy as new evidence becomes available. However, as we go through the process of digitization, there have been identified needs at the programmatic level to improve the L1, such as providing more precise recommendations, having a standardized format, and a standard glossary of terms. This work is closely linked to the living guidelines approach that's being developed by our Quality Norms and Standards Department. L2 is the operational layer that essentially consists of business requirements document that would be very familiar to business analysts in the room who are responsible for translating systems requirements into standardized documentation. This requirements document we call the Digital Adaptation Kits, or DAKs, which consists of key components such as user scenarios, business processes, and workflows following the BMPN standard, decision support logic tables with pseudocode, and a data dictionary mapped to semantic standards such as ICD-11, and calculation of indicators using the same data outlined in the data dictionary. Moving now to L3, you see here in the middle, these are the machine-readable recommendations that translate the requirements outlined in the DAKs, or digital adaptation kits, into software-agnostic code, leveraging the HL7 FHIR standard and other relevant interoperability standards to not only facilitate the adoption of WHO evidence-based recommendations with fidelity, but also facilitating the adoption of interoperability standards into digital health solutions. So a great 2-for-1 execution in the L3. The L4 is now moving to the executable recommendations, including reference software that contains the normative content from L3, but also some helpful executable code that can be leveraged to support the adoption of the guidelines into software systems. Maybe not starting from scratch, but building from a solid foundation that can accelerate country uptake of SMART guidelines. And then L5 are the dynamic guidelines. And these are something that we have not created yet as WHO, But we're working towards, with the theory of change, that if countries are increasingly adopting standards-based recommendations and software at the country level, we can leverage data collected at an individual level and leverage technologies such as AI to also inform the development of the guideline itself and potentially deliver more dynamic recommendations that are easily contextualized to the country level. So level 5 really closes that feedback loop that we've all been dreaming about in a possible digital future. I'll quickly go through this example for immunizations, whereby the L1 would include, for example, the recommended schedules and indicators. The L2 would include the workflows and clinical decision support needed to be embedded in an electronic immunization registry. And the L3 would include a FHIR implementation guide that reflects the data, logic, and forms required for an electronic immunization registry or EIR. The L4 would be a reference electronic immunization registry application that can be adapted and updated to the country context. And the L5 would be moving towards leveraging this work for precision public health and the feedback loops we spoke about earlier. The SMART guidelines are intended to just be generic guidance that countries adopt, similar to how WHO global guidelines are currently being adopted. There is an expectation that all layers of this framework will need to be adapted by countries. However, SMART guidelines are curated for the specific intention of adopting them into digital systems. In the future, we even foresee the possibility of establishing a subscription model that countries can subscribe to the latest guidelines and receive automated update notifications from WHO. The SMART guidelines have many scenarios of use regardless of where countries are in their digital maturity. For example, if a digital system does not exist, then countries can use them to kickstart and accelerate the requirements gathering process, thus reducing the time and the resources needed to build them, while also ensuring they have interpreted recommended health policy correctly. If a digital system is already established, which is more often the case, then the SMART guidelines are an opportunity to update existing systems to the latest recommendations from WHO and move towards adopting interoperability standards that will help unlock the full potential of digital systems. And if a country is not ready for digital at all, then the review and use of these SMART guidelines can actually also help improve efficiencies in non-digital processes by even simplifying paper forms and reducing the need for duplicative data collection. It is important to note, however, that in addition to the content itself, the SMART guidelines are built to ensure systems are better designed with the principle of collect once and use many times. Instead of spending time on reporting, the idea that a digital system should focus on the health workers and support them in their day-to-day workflow in provision of care. Data that is then collected through the care delivery process, the primary use of data, can then be used to automate the aggregation of indicators, which we also refer to as the secondary use of data. Although we have seen SMART guidelines being primarily developed for provider-side applications, as we spoke about the immunization registry just now, we're also leveraging interoperability standards with the vision to enable digital personal health records, where individuals can also have access to their own health records wherever they go in a digital format. We're not only looking to support the digitization of worker tools using the SMART guidelines methodology, but we're also working to connect it to individually held records as well. Furthermore, these SMART guidelines themselves can also be used as benchmarking tools for the WHO Digital Clearinghouse to assess digital tools for compliance to WHO recommendations. The Digital Health Clearinghouse is intended to pre-qualify digital health solutions so that countries know which tools are consistent with WHO recommended best practices. At WHO, we see the SMART guidelines work as fundamentally shifting how WHO supports countries in the digital age, thus requiring institutionalization across the entire organization through process improvements, the development of technology to support the smart guidelines ecosystem, and fundamentally support and capacitating people to be able to create, adopt, and leverage the smart guidelines content. Our team in the Digital Health and Innovations Department is working to support technical program areas, such as the Global Tuberculosis Program, the HIV program, and the Maternal and Child Health programs, to develop smart guidelines. And we are also working with the Quality Norms and Standards Department to fundamentally change WHO's handbook on guidelines development. Our team is also working among many other parts of the organization, such as with the Data and Delivery for Impact Division, to ensure that the WHO family of international classifications is embedded within the smart guidelines work. Working together with many of you in the room and others around the world, we have a full ecosystem of tools planned for supporting the smart guidelines curation, testing, dissemination, adaptation, and execution. And we're working closely with partners such as HL7 and Google to ensure that the correct tools is available to support the development of this work. Currently, we have a number of smart guidelines in progress, and I won't read through all of these areas now, but it's important to emphasize the fact that these smart guidelines are being developed and quality assured with the health domain experts who are responsible for developing the L1 guidelines themselves. And we are hoping to eventually have all smart guidelines available for all the areas of primary health care. A number of smart guidelines are already available now on our website and our GitHub. We have compiled a number of related peer-reviewed publications related to smart guidelines work, and these links are available here and on our website. I want to just spend a few minutes with one final exciting piece of work supporting member states and partners in their transformation. And this builds on a lot of the groundwork which the smart guidelines establish. This includes a new global digital health certification network that supports a growing number of member states, enabling the sharing of individually mediated, credentialed health information across borders. Now, that may sound like a lot of buzzwords, but I just think about digital yellow cards or portable health records that individuals can carry as they travel for routine or emergency purposes. This network is now operational as of July of this year, and we're gradually migrating countries to join this new global network, which allows for this exchange of trusted, credentialed health information, strengthening global health security, but also making it easier for people to carry their immunization records and essential health information as they travel across borders. I want to thank you all for your time, and we look forward to your support in helping people and countries move from an analog reality to a digital one, where health for all can be realized as we harness the power of technologies and rethink health systems with these new paradigms, freeing them from the limitations of the paper-based realities in which many of these systems were designed.